بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أعزائي طلاب طالبات المستوى الرابع بكالوريوس طب وجراحة الفم والأسنان، أهلا وسهلا ومرحبا بكم في اللقاء الثالث من لقاءاتنا التعليمية في مقرر طب الفم. في هذه المحاضرة الثالثة سنواصل الحديث عن الكلينيكال اكزامينيشن بارت 2. What is the clinical appearance of the lesion؟ في المحاضرة السابقة تحدثنا عن how to perform a thorough clinical examination regarding intraorally and extraorally and the general condition of your patient. Now, after you perform an intraoral clinical examination, you need to describe the presence and the clinical characters, the clinical appearance of your findings regarding filling the cyst sheet and reaching the final diagnosis. So, there is a different clinical appearance and clinical features for each lesion which should be differentiated, and the clinical description of your finding will help you to reach the differential diagnosis regarding the similarities of your lesions, and also we will help you in the final diagnosis of your case. The references of the third lecture as well: the color atlas of common oral diseases, the 4th edition, in addition to the textbook of oral and maxillofacial medicine, the 2nd edition. As we mentioned above, the clinical examination of the lesion will vary from lesion to lesion, from other condition to other conditions. The aims of the third lecture: at the end of this lecture, the students should be able to describe the basic knowledge and of the regarding the intraoral and extraoral examination. As well, the student should be able to perform general examination and correlate the clinical findings with the systemic condition of your patient. What is the general condition? What is the supposed medical problem of your patient? You should be able to correlate them with the clinical findings regarding the clinical appearance of the lesion. The students should be able to present the concept of systematic oral examination, and also the student should be able to present and express the clinical and the definite clinical presentation of your finding intraorally or even extraorally. In this lecture, we will talk about many descriptions or many clinical appearance patterns of many lesions. There is a wide variance of clinical presentations of the oral maxillofacial lesions, starting from papules and plaques, and the lesions may be presented as a nodules, or it is a tumor, or it is a vesicle, or it is a pustule, which is a pus-filled vesicles. The lesions may be also presented as a bullae, which is larger than vesicles, or may be presented as a cyst, which is more larger and maybe in the bone, hard or soft tissues. And also these lesions may be presented as a petechia or subcontinuous bleeding. Also, there is some other clinical presentations of the lesions, such as patches, which is a discoloration of the lesion from the surrounding tissue, non-raised lesions. Or these lesions may be presented as a erosion or as an ulcers, which is regarding or included within the ulcerative presentations of oral maxillofacial lesions. Also, the lesions may be presented as a wheal or a scar, which is a thick or fair nodule raised fibrous tissue, may be resulted from surgical condition or other diseases. We'll talk about it in detail. The clinical presentation of some lesions may be presented as a fissures also. We'll talk about it. What are the lesions that presented in the oral cavity as fissures, and also may be presented as a sinus, such as infections which lead to other side or other position as a drainage activity of the lesion. Also the lesions may be presented as a macules, which is a discoloration from the surrounding tissue smaller than patches. All these clinical presentations, we'll talk about it with a clinical examination of a clinical cases through this lecture. Lesion may be presented in the oral cavity as a macule or patch, or may be presented as an erosion, or may be presented as an ulcer, and also may be presented as a wheal. Some lesions presented in the oral cavity as a scar, and some of those presented as a fissured or fissuring in the oral mucosa or in the tongue surface, or may be presented as a sinus. Other lesions may be presented as a babule, and some presented as a plaque. Other presented with nodule appearance, and some of that lesions may be presented as a tumor. There is a specific appearance of some lesions which is called a physical or pustule or bulli, which we called it a vesiculobullous lesions. Vesiculobullous lesions. Cyst also is a clinical appearance of some lesions, and petechiae is a clinical appearance of the other. So clinically, some lesions presented as, in general, as an ulcer or ulcerative lesion, and some of lesions presented as a vesicles or bulli, and some presented as swellings, tumors, and the other presented as a pigmentation or red white lesions. Red and white lesions or pigmentations may be presented as a macules or as a patch. Ulcerative lesions may be presented as an ulcers or as an erosions. This is ulcerative oral lesions. Some of the lesions also, as we mentioned before, vesiculobullous lesions. The vesiculobullous lesions may be presented as a vesicles or pustules or bulli, and some of the lesions presented as swellings. What does this descriptions means? What is the appearance, clinical appearance of each of those descriptions? We will start with pigmentations. The macule. Macule, when we find a circumscribed, non-raised of epidermis, alteration in the color from the surrounding tissue. So it is circumscribed, non-raised. The level of the lesions is not exophytic. We had an exophytic lesions. The exophytic lesions are raised lesions. There is an elevations, but the macule is non-raised lesions. Just there is a discoloration at the level of the oral mucosa or the skin. So just the macule, there is just a discoloration, non-raised, circumscribed, differ from the surrounding tissue color. So this is the macule. The example of the macule is the melanotic macule, which is a oversecretion of melanin by melanocytes presented in the superficial layers of the skin or the buccal mucosa or the lips. The second type of pigmentation is the patch. The patch really resembles the macule, but the patch is larger than the macule, is not well circumscribed. The patch diffused relatively compared with the mucocele is diffused pigmentation. Also the patch is non-raised. Erosion, as we mentioned, is one of the ulcerative lesions. So there is a peeling of the superficial tissue, but not including the basement membrane and the connective tissue, is a superficial removal or denudation of the epithelium above the basal cell layer. In the histology, as you studied in the second and the third levels, we have a epithelium, we have the epithelial layers and also epithelial cell layers. There is the basement membrane, underlying it there is the connective tissue which contain the blood vessels and the fibrous tissue and other tissue. So the erosion just presented in the superficial layers, not touching the basement membrane. This is the basement membrane, this is the epithelial layer, and this is the connective tissue layer. So it is a superficial erosion, superficial denudation above the basal cell layer. So we called it an erosion. But the ulcer, the loss of epithelium that extend below the basal cell layer, so there is a clearly defined ulcer, deep. So the ulcer including the epithelial superficial layers, mucous membrane, and also including the basement membrane reaching the connective tissue. So the main difference between the erosion and the ulcer is that the erosion not reaching the basement membrane, but the ulcer reaching the basement membrane, reaching the connective tissue, so it's extend below the basal cell layer. And examples of traumatic erosion may be due to traumatic denudation due to hard food or thermal trauma, and the examinations of ulcers is due to traumatic ulcer or aphthous ulcers. So the ulcer is differentiated from the erosion by the depth. Wheal. The wheal is a pinkish red edematous and serum filled babule or plaque. Serum filled, so there is a fluid content in this lesion. This is the appearance of the wheal. Elevated lesion, exophytic lesion, elevated, containing a fluid which is a serum fluid, and also resemble a babule or the plaque. Also we have the scar. Some lesions presented in the oral cavity as a scar. The scar is a permanent mark indicating previous wound healing. Some of the wounds healed by formation of a scar. As we stated before, there is two types of healing: primary intention healing, and healing by secondary intention. Usually healing by secondary intention leading to scarring in the tissue. So healing by secondary intention means that there is no any intimate contact between the borders of the wound. If there is no contact between the borders of the wound, the healing process will be completed by secondary intention leading to scarring in the tissue, as this clinical appearance. This is the scar, and the scar is a permanent mark indicated previous wound healing. Fissure. Fissure is a cracks or a grooves presented in the oral mucosa or the skin or the tongue. Most commonly in the oral medicine, the fissure is presented in the cases of fissured tongue. Fissured tongue indicated local factors or local causings, and may indicated systemic diseases. Fissuring is a linear crack in the epidermis, as we see in the clinical photo and the graph. Sinus is a tract leading from separative cavity, cyst or abscess. So the sinus, there is a separative cavity suppurative cavity means the cavity containing pus. This pus try to exudate, forming a tract. We called it a sinus. This clinical photo indicates a sinus tract resulted from a pus formed due to traumatic lesion in the central incisors. This is the fracture of the central incisor and the other central incisor. This trauma may lead to bulb necrosis. The bulb necrosis will form a pus or a cavity of pus. This cavity of the pus may need to go throughout the cavity, making a sinus tract. It is maybe a tract for a cavity, suppurative cavity, cavity containing pus, or cyst or abscess. The babule is an exophytic lesion. Exophytic means there is an elevation of the lesion. The lesion is not at the level of the surrounding tissue, so it is an elevated exophytic lesion, elevated solid lesion, less than 1 centimeter in diameter. Solid lesion means that this lesion does not contain any fluid. No fluid, no pus. So it is a solid lesion. We called it babule. This babule might be diagnosed as a fibroma or other definite diagnosis according to the histopathological findings. The plaque, it is a flat raised area larger than 1 centimeter in diameter. So this is a plaque resemble the babule, but the plaque is larger and the plaque is flat, larger than the babule, and it is plaque. Nodule, babule, and plaque and nodule, all of them are raised lesions. The differences between the plaque and the babule is the size of the lesion, and the plaque is relatively flat compared to the babule, but the nodule has a dimension of depth. Dimension of depth means that it is an elevated lesion, but it has a dimension of depth, so it's extended above and extended also deeply. There is an extension deeply and there is an extension superficially. So the main important note in the nodule, it is a raised solid mass and has a dimension of depth. Dimension of depth. This dimension of depth, when we call this lesion or prescribed this lesion as a nodule, we can't describe the nodule without palpating the lesion. So we need to do a digital examination of the lesion and assess if there is any dimension of depth. The nodule mainly less than 1 diameter in size, but the tumor solid, raised, benign or malignant, that has dimension of depth as well as the nodule, but it is larger than the 1 centimeter in diameter. So the nodule resemble the tumor, but they are different in size. The tumor is larger than nodule, as well as the babule resemble the plaque. So the plaque is larger than the babule. Nodule and tumor are different completely from babule and plaque by they has dimension of depth, dimension of depth, or what we called it induration. Physical, this is the first one of the fascicular-bullous lesions. Those lesions had a fluid or pus or whatever inside the lesion. So the physical is a fluid-filled, skin elevated lesion less than 1 centimeter in diameter. The physical also, it is a circumscribed lesion, fluid-filled, elevated, and its diameter less than 1 centimeter in diameter. The pustule is physical, filled with a purulent exudate. This is the difference between the physical and the pustule. Pustule means that there is a pus. So the content of the lesion is pus, purulent exudate. Bullae, fluid-filled mucocutaneous elevations greater than 1 centimeter in diameter. This is the difference between physical and bullae. Bullae larger than physicals. Bullae larger than physical. So the bullae fluid-filled, the physical fluid-filled, but the physical is smaller than bullae. The pustule is a purulent exudate containing lesion. The cyst, an epithelium lined. So there is a cavity lined by epithelium. Epithelium lined, fluid-filled mass in the dermis, or in the subcutaneous tissue, or in the jaw bone. So the cyst may be formed in the dermis, or subcutaneous tissue, or mucous membrane, or even in the bones of the jaw. The cyst may be fluid-filled or may be secondary infected. That means that the content of the cyst may be the pus. Petechia is a purpuric lesions 1 to 2 millimeter in diameter, and the larger we called it ecchymosis. So this is a purpuric lesions due to subcutaneous bleeding. Those patients complaining from hematological disorders. Or bleeding disorders, or what we called it a coagulopathies. So the normal tissue in histopathology appears as epithelial tissue, epithelial layer, basement membrane, and connective tissue. This is the clinical normal, the histopathological normal appearance. Clinically, this is the normal appearance of the oral cavity. So normal tissue should be normal from the appearance and normal from the view of number and the size and the architecture of the cells. Soft tissue, gingiva and teeth and the occlusion should be appears normally. But if there is any abnormalities in the tissue that can be evaluated histopathologically, there is some of disorders. One of them is called atrophy. Atrophy means that there is a decreased size, not the number, size of the cells. So there is a decreased size of the cells, the same number but decreased size. This is the normal appearance of the tissue, and this is the atrophic tissue. Histologically appearance. Post-stroke, after stroke, tongue muscles can be atrophied, as we see in the clinical picture. Hypertrophy is the increased size of cells opposed to the atrophy. The increased size of the cells, this is the normal, and this is the hypertrophy. hypertrophy, increase the size of the cells. In the case of facial hemihypertrophy, there is an increased size of the facial tissue in the right or in the left half of the facial appearance, including the tongue also. These clinical pictures identify the patient with facial hemihypertrophy with increased cell size of the one left side of the patient, of the tongues of the patients. So it is a hypertrophic tongue. Hypoplasia means that decreased number. So in the hypertrophy and atrophy we talk about the size of the cells. In the hypoplasia and the hyperplasia we talk about the number of the cells, not the size of the cells. Hypoplasia means decreased numbers of numbers of the cells. So this is the normal tissue and this is the hypoplastic tissue, as we can see in the cases of amelogenesis imperfecta and hypoplastic enamel. Amelogenesis imperfecta presented with hypoplastic enamel. Hyperplasia, on the other hand, increase in the number of the cells. There is an increased hyperplasia of the surface, as we see in the pictures. Hyperplasia of the surface cells as a result of cheek biting. The patient has cheek biting. He bites on his cheek continuously. So as a defense mechanism, the cells increase their numbers to protect the buccal mucosa. So this is the normal number of the cells, and this is the hyperplastic tissue. Cyalometaplasia, some of the lesions presented with clinical pictures, we called it a cyalometaplasia. Metaplasia, altered cell types. Metaplasia means altered cell types and number and also the architecture. So this is the cyalometaplasia, which might be resulted from ecchymosis, or what we called it ischemic condition in that area, leading to cyalometaplastic lesions. Dysplasia, altered in the pre malignant cells. So dysplasia, it is very important to understand it. So the histopathological results of the biopsies mainly explain the dysplastic changes of the tissue. Dysplasia, in this picture we had a leukoplakia. By biopsy, histopathological report mentioned that there is epithelial dysplasia of the floor of the mouth, due to leukoplakia. So this leukoplakia has a dysplastic changes, so it is in the way to transform to malignant lesion. In the dysplasia, the histopathologist will write the report about the stages of dysplasia: mild dysplasia or moderate dysplasia or severe dysplasia. After severe dysplasia, there is a carcinoma in situ. After the tissue reaches the carcinoma in situ or the severe dysplastic stage, it will transform to carcinoma. So the carcinoma, in the carcinoma histopathologically there is abnormal, malignant and invasive cells. In this clinical pictures, there is a cancer lesion, and histopathologically we will find a dysplastic, invasive and abnormal malignant cells. This is the cancer of the hard palate and the alveolar ridge of edentulous patient. At the end of these lectures, we will conclude that we had talking about the clinical presentation or the clinical appearance of the lesion. It is very important to know how to describe your finding and write it in your case sheet, in the patient's case sheet. So it is very important to express and write the suitable and the correct description of your finding in your patient, and write it correctly in the case sheet of your patient. So according to the clinical description or the clinical appearance of the lesion, you will make the differential diagnosis and move correctly to the definite diagnosis. So when we define the differential diagnosis, we say that making the consideration of the similarities. So if the clinical finding is the ulcer, what are the lesions, what are the diagnoses, what are the pathoses that are presented in the oral cavity as an ulcers? If the clinical finding is an erosion, what can this erosion be? What is your definite diagnosis, differential diagnosis for the erosion? If the clinical appearance of your finding is a physical, what are the lesions that presented clinically as a physicals? So it's very, very important to know the clinical appearance of the all oral pathologies or the oral lesions, and what are the similarities to make the differential diagnosis. For example, at the conclusion, if you find a lesion which is presented as a papule, this papule you report is as a clinical finding as a papule. Then when you move to the differential diagnosis of the papule, you will start with fibroma and list the similarities. What are the lesions that also presented as a papule? The second examination is the physical. For example, if you find by clinical examination, if you find a physical in the patient's lip, you will write in your case sheet that in the part of the clinical examination of the lips there is a physicals, and when you move to the differential diagnosis of the physicals, you will mention what are the lesions that presented as a physicals. For example, you will start with herpes labialis and list other 2 or 3 other lesions that presented in the oral cavity as a physicals. So from this differential diagnosis, you will exclude the other diagnosis, reaching the final definite diagnosis may or may not by the helping of investigations. So it is very, very important to express your clinical finding truly and correctly. So the differential diagnosis will depend mainly on the clinical finding, on the clinical appearance of your lesion. The assignment of this lecture which is the third lecture of our course, each student must get a mini report. You will prepare a mini report for one lesion of each of one clinical appearance in these lectures. So all of these lecture of all of these clinical appearance, you need to prepare a mini report mentioning lesions with papule appearance and lesions with plaque appearance, and what are the lesions that presented as a nodule, and so on, starting from papule finishing with wheal. So each student must provide a mini report concluding the lesions that presented as one of the clinical appearance. So the lesions that appears as a papule and the lesions that appears as a nodule, and so on. This assignment will be provided in the assignment sections as a attached Word document as titled Assignment 3 for Lecture 3. Thank you very much for your listening, dear students.